Okay, and we are good to go. All right, good morning, everyone. My name is Morgan, and I am a family nurse practitioner. Sorry, just a little bit of tech problems this morning. I am unable to get my Bluetooth to connect to my new computer, so we'll see what's going on there. So if you hear any background noise, my apologies. Okay, but before we get started, I just want to tell us real briefly some of the cool things that we have at Archer. If you aren't already signed up with us, I highly, highly recommend checking out some of our stuff. So we have all sorts of really cool things here that really help students get ready for their board exams. So if you are a nurse practitioner or you're thinking about becoming a nurse practitioner, join us. We have lots of content that we love to talk through and get people on board with that. So, let me just see where my screen went. Okay. And we are going to dive in this morning and talk about chronic disease as it relates more to the gastrointestinal tract. Okay, and let me just see. There we go. Okay, our learning objectives, just kind of talk really briefly about the anatomy and then go through some assessment and diagnosis. All right, so for a brief review of our overall anatomy, we divide our abdomen into those four quadrants, right? We have our right upper, right lower, left upper, and left lower quadrants. That's kind of how the name that we use to really describe any findings accurately. And it gives us an idea of what lives in which quadrant. If you can recall, up here we have our stomach. Pancreas kind of goes in between those two areas. We also have our gallbladder here, liver mostly on that right upper quadrant. And then we go down into the right lower quadrant. Now, this is a really, really interesting area and where we see a lot of acute things happening. And when I specifically am talking about is this little guy here, your appendix, and it can get inflamed. It can get filled with maybe stool contents. We're not really sure exactly what's causing it. Inflamed and burst, right? Which was a perforated appendix, which is a medical emergency. And something that you always think about when we think about our right lower. However, if you are a female, you have an ovary in that area that can also have, cause some discomfort and stuff like that, more in an acute setting. Now we go over to our left lower quadrant here, and I think of our colon. And down into our colon here, I think a lot about diverticulosis, which is a chronic situation. And then when it becomes acute, we call it diverticulitis. And that's when we'll get into it in just a minute. But when we have the outpouching in that lower segment of the colon, I mean, it can happen anywhere, but this is a really common area. So whenever you have an acute pain in that left lower quadrant, I think of constipation, and then I think of colon issues, so diverticulitis or cancer, right? We can't ever rule that out. Something we should think about. Again, if you have female anatomy, you would have an ovary on that side as well, which can cause issues. So I think about an ovarian torsion. I think about ectopic pregnancy. I think about um, cysts that happen, and as those cysts get larger, it gets more and more painful. And oftentimes on ruptures, where you kind of get some relief, is what a lot of people say, and we can see that. And then if it's a big cyst that's growing on the ovary, would be a little bit more chronic condition, probably over several months, maybe gets bigger, like something like a dermoid cyst or something like that, which develops over time and causes more chronic pain, and then can lead to a torsion, which is a twisting of that ovary due to just kind of the weight, and all of our supporting ligaments can no longer support that ovary because now it has this huge, large cyst on it. Just a quick review, we've talked about this. If you watched the GI last month, where it was more of the cute stuff, we've already covered a little bit about this. But when we're looking at somebody's abdomen, our exam and our physical assessment changes just a little bit. And the reason that we go from, we start with inspection. So we look, I kind of have a patient lay flat. Maybe they bend their knees a little bit, but they're on a bed and you can look and you're looking for any peristalsis that you can see, any masses. Do you have a hernia that's poking through? So you're kind of just looking at the abdomen, seeing if there's anything that strikes you as abnormal. Then you're going to listen. And the reason why we listen before we ever put our hands on a patient is to prevent changing what those bowel sounds would be. So we can activate the bowel just by pressing on the abdomen, right? So doing a little bit of that massage or palpation, maybe even a little percussion, could change what you would have heard. So that's why we listen first, to make sure that we're getting it the most accurate assessment tool with our ears. And so listening to bowel sounds is really, really important. And we're going to listen in each quadrant. And what we're looking for is just that normal sound, low pitch, gurgling. Couple per minute is normal. If we have hyperactive, then we're like concerned, is there some sort of acute GI thing happening? We can also see hyperactive in an obstruction, like early stages of an obstruction. And then hypoactive is the bowel's not moving much. So what's going on? What's putting our bowel to sleep? Is somebody on a GLP-1, right? That's something really big that we have in our world today and something to be asking patients. GLP-1s can cause a little bit of gastroparesis or like slowing down of that GI tract. So we want to ask questions about that if we're not getting those bowel sounds. Percussion, really, really important. I just use my middle finger and tap on it, and you can practice this on your desk, but I also like to practice on a wall. If you have a dry wall, if you've done my other things, you'll know. I say you can find your studs using percussion because you'll hear it when you get over to that dullness of the stud. So you're now your own stud finder, doing percussion on your wall. So we like that. It's a lost art a little bit in medicine. I say use it. It is a very, very useful tool, especially if you're looking for something like stool or a mass. You can really hear the change in somebody's abdomen if you're getting over something like a stool, and that can be kind of reassuring for people. If you can tell them like, oh yeah, it sounds like maybe you're a little bit constipated. I can hear like right, and they can hear it also. Like we hear air, 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 and now this is a little bit of a probably some stool in your lower colon, which would be a pretty common finding, right? Depending on when the last bowel movement was. Palpation, we want to do light pressure and then a little bit more intense pressure. And what we're really looking for is if we can feel any differences in their contour, right? And if you are palpating the liver, does it feel nice and smooth as it should, or are you getting like some abnormals? I did have a patient who had metastatic breast cancer and had cancer had spread into her abdominal cavity, and it was very palpable. So we want to be doing this. I just say do it on all of your patients when you're doing physical exams, because this is how you're going to get really good when somebody comes in with an abnormal, and this is how you're going to learn how to identify those abnormals. Okay, let's move on. Quick practice question. You guys can open up the chat and answer here. A patient with known Crohn's disease presents with unintentional weight loss and reports episodes of cramping, abdominal pain. On exam, the APRN notes right lower quadrant tenderness and a palpable non-pulsatile mass. Which of the following would most appropriately support a suspicion of an intestinal complication? Dullness to percussion in the right lower quadrant, hypoactive bowel sounds with soft non-distended bowel, high-pitched bowel sounds and localized tenderness over the mass, or generalized abdominal distension with diffuse tympany. All right, any ideas? Let me pull up our chat here. Oh, these are over here. Awesome. Oh, get this out of the way. Great. Okay. Really, really good. Okay. All right, C is correct. So high-pitched bowel sounds in this case with localized tenderness over a mass suggests a partial bowel obstruction. So this can be a complication of Crohn's disease due to strictures and formations in our in an inflammatory state. Okay, so that's really what we're looking for. All right, IBS. So let's dive into this a little bit. It is a really common GI condition. It's characterized by abdominal pain, discomfort, and really kind of that core thing is changes in that bowel um, and like our stool consistency. So we don't really know exactly what's causing it, but things like stress, recent GI infections seem to be a little bit more at play in these situations. So we know stress, anxiety, all seem to have like a really big component, and we know how much our body is connected. So it's something that we think about, and we think about maybe serotonin having a role in IBS. We know that there are serotonin receptors in the GI system, so does IBS, anxiety, all of that stuff kind of roll together? It's very much a possibility. So if we have low serotonin levels in the brain, do we likely have them in the gut? And so you feel, that same anxiety feeling, but in your stomach now? Potentially. We don't fully understand it. But what we do know is that we are going to start becoming a detective and trying to understand what it is and what it's not. Okay. So that's a little bit of this allopathic medicine that we practice is we sometimes don't always have the best answers for patients, but we can tell them what it is not and that it's not super dangerous, right? So we're going to rule out these things that will likely lead to a sooner death, and then we come to these functional diagnosis by excluding other diagnoses, okay? And so that's kind of a little bit of what we do with IBS. We can use the Rome 4 criteria, but typically, you're going to do a little bit more of an extensive workup as well. So when we think about that Rome 4 criteria, I really think about what are their symptoms. So do they have pain in relation to their defecation? Do they have change in frequency of stool? And do they have change in the appearance of stool? So we might have somebody with IBS-C, which is more of the constipated presentation, and somebody with IBS-D, which is more of the diarrheal presentation of IBS. And they may go back and forth, okay? They may have that mixed presentation. That's part of what we see in IBS, that they may go back from having, now I'm constipated to the pendulum swinging in, going into a diarrheal state, and kind of back and forth a little bit. When we think about this, the FODMAP diet is something that we always educate patients around, looking for different things. And I never keep somebody on a really exclusive diet, but what we do is like an elimination style diet. So we'll talk about it. We go down to a really, really basic diet, which is not very fun. But we stay there for just a little bit, and then we slowly add in foods and we see, is there anything that's triggering symptoms worse than the other things? Really common, we have wheat sensitivity. So that's different from like celiac disease, which is a complete intolerance, right? Now we're having inflammation and so forth because of that allergy. Wheat sensitivity just means it kind of irritates our bowel. And it probably, a lot of people have a little bit of this. Dairy sensitivity, right? They have less lactase. They're not able to break down dairy the way they would. And this is common. Like I can eat maybe a yogurt I can tolerate, but if I have a glass of milk, it really bothers me. Um, Again, that's a little bit to do with the enzymes in their stomach, and there's some new research coming out suggesting that we can actually slowly increase the amount of lactase that our body makes if, in fact, we're not completely intolerant to lactose itself. There is such thing as a lactose intolerance, and those folks just are just like with celiac disease. There's nothing we can necessarily do. Exposure therapy is something kind of on the rise in the allergy medicine world, which with these nutritional allergies, people are looking at that, and doctors are working really closely. I actually have a friend whose son is highly allergic to a lot and has a lot of actual allergies to foods, and is working out in California with the doctor flying out there, and they're doing microdosing of different allergens over time to build a tolerance to them and allow so through exposure. Um, when we think about IBS here, though, we if we're doing all of our workup, what we're not seeing is inflammation on like a CRP. So we do a general CRP or ESR looking for levels of inflammation. Now, if there was a physiologic autoimmune type thing happening, then we would see that response going up or see that level going up. We would see some changes maybe in absorption levels of things. We might have a little bit of anemia if there was something else going on that was more severe than the IBS. Now, living with IBS, I don't want to downplay it. It is very, very much has a significant impact on people's lives. But what I'm saying is when we do our workups, when we look at colonoscopies, everything looks normal. And that's frustrating for people. And you're going to find that in your practice that when you run a colonoscopy, when you're running labs and you're looking for all these IBD type presentation diagnoses and you're excluding those off of your list of your differential, patients feel like we're not necessarily listening. So it's really important to have those conversations and say, like, I understand that and I believe that you're feeling this way, but luckily it's not X, Y, and Z, right? It's not Crohn's, it's not ulcerative colitis. And that's kind of the way that I have the conversation with people. And it's looking more like this. And so when we start the workup, I say, this is what I'm thinking it could be, and this is what I'm hoping to get off of our list of possibilities. Okay, so that's the workup, and that's how I explain the workup and what we're doing to figure it out. Now, if I can't get people under control with diet changes, with Imodium, with fiber, just lifestyle changes and a little bit of the medication tools we have, then GI can assist in this situation and we can refer out if needed. All right, I have another practice question. I've been trying to do more practice questions. I think people like those. Okay, which of the following characteristics is most consistent with the underlying pathophysiology of IBS? Chronic inflammation with mucosal ulcerations and crypt abscesses, granulomatosis, transmural inflammation with skip lesions, autoimmune mediated villus atrophy in the small intestine, or a visceral hypersensitivity and altered gut-brain signaling without structural abnormalities. Any clues here? What do we see happening in IBS? Ideas. Feel free to answer in the Q&A if you prefer to be anonymous, but if you're okay not being anonymous, or you can direct message me and tell me your answer in the chat. Or all of our people that are on like social media. Awesome. Okay. Yeah, you guys are right. So it is D. IBS is a functional gastrointestinal disorder. It's really marked by that visceral hypersensitivity, dysregulation. We think, like I said, between that gut-brain axis, serotonin being maybe a big player in this, we're not fully sure. Abnormal motility, but we don't see those structural changes on endoscopy, biopsy, colonoscopy. We're not seeing that, okay? However, we're going to talk about IBD next, and this is where we start to see things going on. Maybe one day we're going to have a way to diagnose IBS a little bit better, like we do with Crohn's and ulcerative colitis. I'm not sure. I'm not in GI. I'm in family practice, so they probably can answer some of these questions a little bit more than I can. All right, so we have Crohn's and ulcerative colitis. These are two common-ish autoimmune diseases that involve the GI tract. They're inflammatory conditions, okay? IBD is kind of an umbrella term, and these two diagnoses live underneath of it, okay? And they are different from one another. When we think about Crohn's disease, we think about strictures, inflammation, skip lesions, fistulas. Crohn's can occur at any part of the GI tract. I have given this lecture before, and I always say I remember an 18-year-old at Children's Hospital getting bowel resection after bowel resection because of such severe Crohn's disease. Since then, that was in the early 2000s, treatment has evolved and we have new biologics and DMARDs and stuff like that to get this disease under control. At that point, just lots and lots of steroids were being used. Ulcerative colitis, on the other hand, is really starting in the rectum, and then it progresses upwards and it affects only the colon. All right, ulcerative colitis affects the colon. It starts in the rectum and it works its way up the colon. Now we see some differentiations between how these folks will present differently and how you can decide, is it more like a Crohn's presentation or an ulcerative colitis presentation? All right, so obviously imaging is going to be very, very helpful in diagnosing and differentiating these things. But for exam purposes, it's important to know that when we have Crohn's disease, we likely have that right lower quadrant pain, nausea, vomiting, weight loss, and then non-bloody diarrhea. Okay. On the other hand, when we think about ulcerative colitis, we think of bloody diarrhea, we think of mucus, we think of tenesmus. So tenesmus is that sensation of not evacuating the bowel after you have gone to the bathroom. And so you keep straining and feeling like there's still stool internally. And that is, if you think about the rectum being one of the first areas to be, lots of inflammation happening there. And so maybe triggering of sensation of stool there when it's really just an inflammation of the the intestine itself or the rectal tissues, right? We have abdominal pain that also comes. We're going to look out for toxic megacolon. So that's abdominal distension, fever, severe pain. Anytime you're seeing severe pain, rigidity in the abdomen, with or without a fever, those things should be red flags acutely, okay? All right, so diagnosing and treating this. So we're gonna use talking about these things. So, a patient comes in, they have abdominal pain. It's been going on for several months. At this point, have they lost weight? Any fevers, chills associated with it? If it comes and goes a little bit of intermittent, we're thinking IBS or IBD, right? Those are the thoughts that are going through your head. Those are differential diagnoses. Is it something that has nothing to do with the bowel? We're going to ask about bowel habits, histories, so forth. We're going to do some lab testing. All right, when we're doing lab testing, we're looking for any signs of maybe some bleeding happening. Are we losing blood? Is there some sort of anemia? Or is there an absorption issue of whatever, the dietary nutrition? When we have lots of inflammation going on in our small bowel because of Crohn's disease, that's going to inhibit the ability of the body to absorb our nutrients. So really important to look for those things. We could see on their CBC an elevated white count. We could also see the body's the immune system is going, right? We could also see a little bit of that thrombocytosis. Like I said, elevated inflammatory markers are going to be kind of a hallmark here that we see. Now that's not our CRPs and our SED rates are not specific to the bowel. We could see elevated SED rates in somebody with lupus, rheumatoid arthritis, polyrheumatica, myalgia. Lots of our autoimmune type presentations are going to show inflammation because that's kind of the state that they cause. They cause a hyper-inflammatory state in our body, and we use our non-specific markers to begin our exploratory diagnosing. Okay, so we start there. If we don't see any elevation in that, doesn't mean that we can totally exclude it, but it goes down on our differential if, in fact, they have no elevation in their inflammatory markers. But they also need to be presently having the symptom to have that going on, right? So if you're going like waxing and waning in and out you're not currently in a flare, you might have your inflammatory markers should be at kind of a normal spot in that point. But we're going to do a biopsy, and that's really going to confirm inflammation and the presentation of IBD happening in the colon or at whatever point in the GI tract. So depending on where we think it is, we're going to do a colonoscopy, endoscopy, and figure out what's going on and confirm with a biopsy. So our treatment is really to just put that immune system in check and stop that kind of autoimmune presentation, get that inflammation down, improve overall ability to absorb nutrients and pass stool and let that GI system do its job, right? And so we use things like corticosteroids often, and I will consider starting those if we're waiting to get into GI and somebody's having severe symptoms, depending, it would be something I would think about doing. Now, I'm not starting like a Humira or anything like that. I do have patients who are on those things and we monitor and make sure that we have good immune function because now we're suppressing the immune system, right? So we want to, in primary care, it's our job to make sure people are getting all of their vaccines and that we're taking making sure they're staying up to date on all of the preventative things that we can do. If somebody's on corticosteroids for a really long time, they have a history of Crohn's disease, I'm going to be looking at their bone density and talking to them about that a little bit more, resistance training, making sure we're having adequate calcium and vitamin D in our diet, And if not, are we supplementing? What does their bone density look like under DEXA? All of those things need to be in consideration when you have a patient with IBD, even if you're not managing the IBD yourself. Okay, another practice question. Okay, man, today is going fast. A 28-year-old presents with 6-month history of intra-abdominal cramping, bloody diarrhea, urgency. These symptoms have worsened over the past month. Physical exam reveals mild left lower quadrant tenderness, an elevated CRP, anemia. Colonoscopy reveals mucosal inflammation. Which diagnosis is most consistent with these findings? Is it ulcerative colitis, Crohn's disease, IBS, or celiacs? So just highlight what you know here, okay? And how did we differentiate these two? This is a very much something that you could see on a boards exam, and I want you to be able to feel confident answering this question. I'll give you just a minute. Awesome. So it's ulcerative colitis. Remember, we talked about showing inflammation. It's in that left lower quadrant, which it could be Crohn's disease, right? But what were the key findings? We also saw that bloody diarrhea. Okay, this urgency, having to go to the bathroom. We had elevated inflammation markers. We won't see elevated inflammation markers in IBS. Okay, anemia, we're not absorbing. Maybe we're bleeding a little bit, would be common. Well, we are. We have bloody diarrhea. So there's blood. We're losing blood through our GI system. So like a little bit of a lower bleed coming out there. All right, Crohn's, we have that segmental, transmural inflammation, any part of the GI tract, right? So we could have some in that left lower quadrant as well. But it's the non-bloody diarrhea that we would see there. IBS, again, no inflammation going on there. And then celiac is an autoimmune response to gluten. Really, we're going to see malabsorption with celiac, weight loss, nutrition deficiencies, not so much the non-bloody diarrhea. Okay, another question for you. Which of the following features best distinguishes pathophysiology of Crohn's disease from ulcerative colitis? Okay, is it transmural inflammation affecting any part of the GI? Inflammation limited to the mucosal layer of the colon and rectum? Continuous lesions beginning in the rectum and extending proximally? Or involvement restricted only to the large intestine with no small bowel disease? What do you guys think here? Differentiating Crohn's from ulcerative colitis again. If you're not getting it, this is a very important area to know. Okay, it is in fact A. Okay, so we have those transmural inflammation, any part of the GI tract, mouth to anus, okay, skip lesions, fistulas, strictures, all of that. So very, very, very significant GI chronic disease. Diverticulosis, I just want to touch on this really quickly. Diverticulitis is an acute issue, and you might ask, why are you talking about diverticulosis? It's important, especially if you work in primary care, you know if somebody has diverticulosis. How would you know that? Well, they probably went in for a colonoscopy at some point, hopefully just a screening colonoscopy, and they found, and they see it on a report, you're going to see it on lots of reports of diverticulosis in that lower segment of the colon. It's common. How we differentiate and how I want you to think about it is the outpouching. So when we have diverticulosis, we just have this outpouching, and it puts us at risk for what we consider diverticulitis, which is now inflammation and perhaps the pathophysiology that we think about. This outpouching of the walls can be a little bit genetic, can be related to a life of really low fiber intake, we think. So a little bit of lifestyle. We also think that just age in general. It's the bowel itself is getting these little balloons on the side walls. The side walls are kind of losing a little bit of their integrity, and now they're kind of pouching out in these little balloons. So we have our main tube coming down, and then we have these little pouches. And when we have those little pouches, and maybe we have some constipation, we think that stool can actually get kind of blocked into that little ballooning of the wall. And when that stool sits in there for a long time, what is stool full of? It's full of bacteria, right? And now it's causing an an infection. And so what we think could be happening, or an irritation, maybe it's just irritated at this point. We don't have any compromise. Stool is still where it's supposed to be. It's not getting into the peritoneal cavity. It's not breaking through the mural, through the colon walls at this point. It's not causing necessarily infection yet, but it's at risk of causing that infection. So if somebody has a history of a diverticulosis and they come in with that left lower quadrant pain, you could, put that high on your differential that diverticulitis might be occurring because of what we've seen. And so when we, consider that, depending on their level of stability, do we treat them outpatient or do we send them to the emergency room to be treated inpatient? And that really depends on how stable they are, other comorbidities happening, ability to care for themselves, and so forth. GI is constantly, just like everywhere in medicine, we're constantly evolving our thoughts. So with diverticulitis, really important then to educate your patients. If you start feeling that, to avoid diverticulitis, keeping a diet high in fiber, lots of water intake is super, super important. And if you start feeling like you're getting constipated and starting to feel that pain of a diverticulitis type presentation, switching right away to a clear fluid diet or to a fluid only diet is currently where the evidence lies. Now, for boards exam, they're going to say go ahead and treat with antibiotics because that's still the current best. However, I think we're going to see, the American Family Physicians Journal last year put out an article specifically around diverticulitis about not always needing antibiotics. So just educating people right away. If you have a diverticulosis, you're at risk for a diverticulitis type presentation. Therefore, if you're having this pain, before, when it's early on, early on, go ahead and just go to that fluid diet only and see if you can pass it. Now, if things get worse, if you're having fevers, chills, anything like that, pain's getting worse, obviously that's either going to an urgent care, emergency care setting, or coming in and seeing your primary care provider, depending on the availability, and making decisions based on their level of stability. Okay. Some people do need to be hospitalized for this. It can get bad. If we do nothing and we just leave it, we don't change anything and we don't catch it, we don't address it, what can happen is perforation and abscess formation and toxic, sepsis, because now you're getting bowel content via perforated bowel into the peritoneal cavity, which is a bad, bad deal. Okay, so I don't want to belittle, I don't want this to feel like it's something you can ignore, but how can we be preventative? And that's what I think about in the primary care setting when you see the word diverticulosis on on a screening colonoscopy. Okay, that means we really need to hit our fiber. We really need to hit water. And then this puts you at risk, which lets me know if you're having left lower quadrant pain, this is what I should be thinking. And this is what I need to do right away. We confirm with a CT and we can treat with antibiotics, so forth, depending on, again, level of stability. Do you have any questions about that? That wraps it up for today. I wanted to get a few more questions out for you guys. I'm sorry. But we have lots and lots of questions in our Q bank. It's an excellent way. I say do 25 to 50 questions per day if you're studying for your boards, one long exam per week. So go ahead, sign up for our SurePass. It is awesome. And we can, show you all of these really great on-demand videos to talk about things a little bit more in depth than what we could do today. And then we also have tutoring. So Hiva and I are both tutors, and we love working one-on-one with people to help them get ready for their boards. We also have one-day live review coming up in December. So if you are getting ready for boards exam, I highly recommend signing up with us. December 12th, it's a Friday. We go 8 a.m. to 5 p.m. Central Standard Time. So 7 for me in Mountain, 6 on the West Coast, and then what does that make it? 9 on the East Coast. I have to do all of this. We work with people from all over the country all the time. So always trying to keep my time zones correct. And sometimes we have people internationally tuning in. So if you're international, welcome. It's so great to have you. And again, we'll see you soon. Next week, we have more free webinars coming for you guys. But reach out and check out the offerings at Archer. You know, we're here to support you guys, make you feel really confident and ready for your boards exams so that you can go out and do the great work that nurse practitioners do. All right, take care. Have a good day. Bye, guys.